Picture this. A 65-year-old man walks into your clinic. Heart failure. Ejection fraction 32%. He's supposed to be on 4 drugs. He's on 1. And he's been admitted twice this year.
And he's not unusual, is he? The real-world data on heart failure medication adherence is terrible. We have 4 drug classes that each independently reduce mortality: beta blockers, ACE inhibitors or ARNEs, mineralocorticoid antagonists, and SGLT2 inhibitors. And most patients in real-world practice never get all 4.
Which raises a question that sounds almost too simple. What if the problem isn't which drugs to prescribe, but how many pills we're asking patients to take? A new randomized trial published in Nature Medicine last month tested exactly that. It's called Polyhf.
A polypill for heart failure. That's a provocative idea. But before we get into it, I want to know 3 things. Who was in the trial? What was the comparator? And does the effect size actually matter clinically?
The Polyhf trial was run at 2 hospitals in Dallas, Texas. Parkland Hospital, which is a safety net county hospital, and Clements University Hospital. And the population really matters here. Median age 54, 54% Black, 68% uninsured or on county indigent programs, frequent food insecurity and housing instability.
So this is a population where adherence is genuinely hard. Not because patients don't care, but because life is complicated. Multiple pills mean multiple copays, multiple pharmacy trips, multiple chances to forget. I can see why a polypill might help here specifically.
Exactly. 212 patients, all with ejection fraction 40% or below. They were randomized to a once-daily polypill containing metoprolol succinate, spironolactone, and empagliflozin, or to individual drugs titrated separately.
Let me make sure I understand the composition. Beta blocker, MRA, and SGLT2 inhibitor in 1 pill. But the 4th pillar, the RNI or ACE inhibitor, was still separate. So it's not a true all-in-one pill, it's 3 of 4.
Correct. The renin-angiotensin system inhibitor stayed as its own pill. The polypill combined the other 3 classes, and the metoprolol was available in 4 dose strengths within the polypill, so there was some titration flexibility.
And the comparator wasn't just usual care, was it? This is critical.
No, it was enhanced usual care. The study team actively helped titrate the individual drugs, provided the medications at no cost, and coordinated with the patient's own cardiologists and primary care doctors. So this was the polypill against the best possible version of individual drug management.
That's a fair fight, not a straw man, which makes any polypill benefit more credible. So what did they find?
At 6 months, the polypill group had a 3.3 percentage point greater improvement in ejection fraction, measured by cardiac MRI. The primary endpoint, statistically significant with a p-value of 0.039.
3 percentage points. Let me be honest about what that means. A normal ejection fraction is above 55. We're talking about moving from, say, 30 to 33. The confidence interval was 0.2 to 6.4. It barely crossed the significance threshold. Is that clinically meaningful or is it noise?
That's exactly the critique that John Mandrola raised. He's a cardiologist and one of the most respected evidence commentators in cardiology. He pointed out that ejection fraction can vary by a few percent just based on who's reading the scan, and he noted that ejection fraction is a surrogate endpoint. Patients care about staying alive and out of hospital, not a number on their echo report.
That's a fair critique, but weren't there harder endpoints too?
Yes, and this is where it gets interesting. Heart failure hospitalizations and emergency department visits were 60% lower in the polypill group, adjusted rate ratio of 0.4, and adherence, measured not by self-report but by actual blood drug levels using liquid chromatography and mass spectrometry, was 79% versus 54%.
Blood level adherence, that's important. Self-report overestimates adherence by 20 to 30% because patients tell you what they think you want to hear. So a 25 percentage point gap in confirmed blood-tested adherence is genuinely large. That's not a measurement artifact, that's real.
That's the mechanism. The benefit parallels what we've seen in hypertension polypills over the last 15 years. Fewer pills, better adherence, and adherence is the rate-limiting step in heart failure therapy. The drugs work. They've been proven in dozens of trials. The problem is getting patients to take them.
But Mandrola made another point that's worth wrestling with. He noted that the enhanced usual care arm had 78% of patients on all 4 drug classes by 6 months. In the real world, that number is closer to 15%. So even the control arm in this trial was unrealistically good compared to actual practice.
Which cuts both ways. On one hand, it means the polypill beat an unusually good comparator, which strengthens the result. On the other hand, Mandrola's point is that both arms were highly selected. The investigators reviewed nearly 5,000 patient records to enroll 212. That's a lot of exclusions.
So the trial population may not represent the patients we actually see. A well-resourced Australian patient with good health literacy and a supportive GP might already have decent adherence. Would the polypill help them as much?
Maybe not as dramatically, but even for engaged patients, simplifying the regimen reduces cognitive load. And for your heart failure patients who are struggling, the ones who keep coming back with exacerbations, this trial gives you a framework. The problem may not be that they need a different drug. It may be that they need fewer pills.
And there's a practical step we can take right now. When you're starting or optimizing therapy, think about whether you can consolidate. Use combination tablets where they exist. Synchronize timing so everything is taken once daily rather than spread across the day. Those structural changes may matter more than which specific molecule you choose.
Watch for the commercial development too. A heart failure polypill isn't commercially available yet, but this trial will accelerate interest. If it reaches market, you'll have the evidence base to support it.
All right, let's move to story 2. Something for your wife.
Group B strep is the leading cause of sepsis and meningitis in newborns. In Australia, we screen women at 36 weeks and give intrapartum antibiotics to carriers. It works for early onset disease, meaning infection in the first week of life, but it has real limits.
It doesn't prevent late onset disease, which happens between 1 week and 3 months. It requires screening infrastructure that isn't available everywhere, and up to 40% of women in labor end up receiving antibiotics, which drives resistance and disrupts the neonatal microbiome.
A maternal vaccine would bypass all of that. Antibodies cross the placenta, protect the baby for the first months of life. We already do this for pertussis at 28 weeks. We do it for RSV. GBS is the next logical target.
And the GBS6 vaccine is a hexavalent conjugate vaccine. It targets 6 capsular serotypes, which together account for about 98% of invasive infant disease worldwide. The phase 1-2 trial was published in Nature Medicine, 216 pregnant women across South Africa, the US, and the UK.
The key finding was robust antibody transfer to infants, with geometric mean transfer ratios of 0.6 to 0.8. That means the infant's antibody level was 60 to 80% of the mother's. Safety was similar to placebo, including obstetric outcomes, delivery mode, and infant adverse events.
But here's what makes the development story genuinely interesting. Beyond the clinical data, no GBS vaccine has ever been licensed, ever, in the history of vaccinology.
And the reason is a numbers problem. A clinical efficacy trial would need over 80,000 pregnant women because the disease incidence is relatively low in countries that have screening and prophylaxis. That's prohibitively expensive. No company would fund it.
So the regulatory pathway is genuinely innovative. Both the FDA and the European Medicines Agency have agreed in principle that licensure could be based on an immunological correlate of protection. That means a threshold antibody level that predicts disease risk reduction rather than showing actual prevented cases in a massive trial.
That's a paradigm shift. It's how we license pneumococcal and meningococcal vaccines. Establish the antibody threshold in observational studies, then show the vaccine hits that threshold in a smaller interventional trial.
And Pfizer's phase 3 trial is already recruiting. It's called BEATRIX. 6,000 pregnant women, randomized, placebo-controlled, double-blind, primary completion in late 2028. So this isn't hypothetical. This vaccine could be in clinical practice within 3 to 4 years.
For your wife's obstetric practice, the implications are significant. A successful GBS vaccine would replace all supplement intrapartum antibiotic prophylaxis. It would protect against late-onset disease, which current screening can't prevent, and it would be especially impactful in resource-limited settings where screening isn't available.
There are still unanswered questions, though. How long does protection last? Will it cover preterm infants whose antibody transfer is incomplete? And the RSV maternal vaccine had a signal for preterm birth, so safety monitoring in phase 3 will be critical.
Story 3. For your anesthetic practice, the EPOCH CardioLink 10 trial tested bilateral superficial parasternal intercostal plane blocks for sternotomy pain, published in the Lancet Regional Health.
Let me orient myself anatomically. This is a fascial plane block targeting the anterior cutaneous branches of the intercostal nerves, T2 through T6. The catheters go between pectoralis major and the intercostal muscles, placed under ultrasound guidance at the T4 to T5 level.
318 patients across 4 Canadian centers. Ropivacaine, 0.2% via indwelling catheters for 48 hours versus saline placebo. The primary outcome was opioid consumption at 72 hours in morphine milligram equivalents.
And the result was a reduction of about 21 morphine milligram equivalents over 72 hours. Statistically significant. But let's be honest about the magnitude. 21 MMEs over 3 days is roughly 1 less oxycodone dose per day. That's modest.
Pain scores were not different between groups. Quality of recovery scores were not different. ICU stay, hospital stay, delirium rates, all similar. So this is an opioid-sparing effect without a clear patient-perceived benefit.
Which raises the question we always face with opioid-sparing interventions. We know opioids cause harm in cardiac surgery patients. Delirium, prolonged ventilation, ileus, prolonged ICU stay. But if the block doesn't improve the things patients actually notice, is it worth the extra time, the catheter placement, the risk?
The authors position it as a pragmatic addition to multimodal analgesia, and there's important broader context here. A network meta-analysis published last year compared all the chest wall fascial plane blocks, erector spinae plane blocks, parasternal blocks, pecto-intercostal blocks, transversus thoracic blocks, 1,466 patients across 24 trials.
And erector spinae plane blocks came out on top for opioid reduction, about 45 fewer milligram equivalents over 24 hours. But there's a problem with ESP blocks in cardiac surgery.
Right. ESP blocks are posterior, they're technically more demanding, and critically, studies of local anesthetic spread show that ESP doesn't reliably cover the parasternal area. The anterior chest, where the sternotomy incision actually is, may not be adequately blocked by ESP alone.
So combining ESP with a parasternal block might give you the best of both worlds. ESP covers the lateral and posterior chest, while the parasternal covers the sternotomy incision directly.
And that's exactly what several ongoing trials are testing. The rationale is anatomically sound. The ESP block covers the dorsal rami and the lateral chest wall. The parasternal block covers the anterior intercostal nerves that innervate the sternum. Together they provide comprehensive analgesia without the bleeding risk of epidural or paravertebral approaches.
For your rural anesthetic practice, the practical takeaway is this. Fascial plane blocks are replacing neuraxial techniques in cardiac surgery because they're safer in fully anticoagulated patients on cardiopulmonary bypass. The evidence base is growing rapidly. The parasternal block specifically is easy to place, safe, and provides a modest opioid-sparing effect. It's not transformative on its own, but it's a useful addition to your toolbox.
Quick hit before we wrap up. A study published yesterday in Nature Communications looked at GLP-1 receptor agonists in a population we've been flying blind on, dialysis patients with diabetes and heart failure.
Every major GLP-1 trial, from LEADER to SUSTAIN to REWIND, has excluded dialysis patients. We extrapolate down, but we've never actually studied them. This team used the TriNet X electronic health record network to emulate a randomized trial. Over 2,500 matched pairs, new users only, active comparator against DPP-4 inhibitors, which are the default choice in this population.
The GLP-1 group had 28% fewer cardiovascular events. All-cause mortality was about a third lower, and this held up across sensitivity analyses and in a separate dialysis-coded subset.
This is observational data, not randomized. There could be residual confounding, but it's the best evidence we're likely to get in this population, and a randomized trial may never happen. The The practical point is this. DPP-4 inhibitors have been the reflexive choice because they're renal safe, but safe is not the same as beneficial. GLP-1s may actively protect the heart and blood vessels, even in the most vulnerable patients.
And notice the callback to the Polypill discussion. In both cases, the question isn't just which drug to use, it's whether structural barriers, pill burden, access, cost, renal function are preventing patients from getting the therapy that would actually help them.
That's the thread connecting today's stories. In heart failure, the Polypill addresses the pill burden. In dialysis, the question is whether we're defaulting to safe but suboptimal therapy. In cardiac surgery analgesia, we're reconsidering whether neuraxial techniques are worth the bleeding risk when fascial plane blocks exist.
Let's recap. 3 practice-relevant takeaways. First, a Polypill strategy for heart failure improved adherence and reduced hospitalizations. The benefit was about getting patients to take their drugs, not about the drugs themselves. Second, the GBS 6 maternal vaccine showed robust antibody transfer with a reassuring safety profile. Phase 3 is underway, and it could reach clinical practice within 3 to 4 years. Third, parasternal intercostal plane blocks modestly reduce opioid use after cardiac surgery. They're safe and easy to place, but not yet transformative.
And the broader theme, the evidence is pushing us toward pragmatic, structural solutions, simplifying regimens, reconsidering default choices, making the right thing the easy thing to do.
See you next time. Stay sharp.